So good afternoon, everybody. So thank you for joining us for this breast committee meeting, and please take your seats. So we're going to deviate a little bit from the agenda that you see up there in the screen. So there's a person with us who actually probably contributed to the life of women with breast cancer much more than many of us, and that's Bill Barlow. So Bill is our clinical trial statistician, and this is his last meeting with us because he's retiring after 20 years with SWOG. I think few of us could actually say that you really changed the life of women, millions of women across the world for the better. So he designed really the trials that led ultimately to the introduction of the recurrence score, so that patients with 24 or more get chemotherapy and saves their life. Of course, Kathy Albane led the trial, the 8814, which were analyzed for the recurrence score. And then, of course, the RX responder study demonstrated that older women don't need chemotherapy at all if their recurrence score is low, and younger women might save their life. So Bill, congratulations for doing all of this with us and for all the women with breast cancer. And thank you. So in addition to these nice words, you actually get some nice surprise gifts as well, that I hope the post will deliver to your home on Monday morning. And we also have another surprise for you, which will come via technology. So I would like to ask Dan Hayes to say a few words about you, because Dan, I think, started at SWOG around the same time as you did, like 20 some years ago. So Dan, you are on, and we will move your slides. Thank you for sending your slides to us.
Thank you. And I'll start out. I'm getting an echo. Let me see.
Yeah, so that's probably your computer
Can you
and
hear
your
me now?
system, but we hear you very well. Yeah, we hear you completely clear without any echo.
Okay. Hang on. Sorry. Okay. Well, I have echo, but I want to start out by echoing everything that Lajos just said. This is a bittersweet moment for me, but I'm proud and honored to get to give a few words about Bill, who has been a colleague, an inspiration, and a friend over the last 20 years. Next slide, please. So when I was asked to do this, like everybody, I went to Google and tried to find a picture of Bill I liked. Next slide. And this was the first one I found. And I'm pretty sure this was not our Bill Barlow. This one seemed to do nothing but Father James Barlow. I found the second one, and he was a clergyman, and Bill is not a clergyman. I found the third one, and this guy's a scientist, but to my knowledge, Bill has little in common with him except the gray hair. Bill is not a crystallographer. And finally, I found this Bill Barlow, who played basketball for the University of Kentucky, which is not KU, Andy. And he, I've never seen Bill play basketball, so I don't think it was that. Next slide. This is the real Barlow. And Bill has been working with us now, as Osho said, for 19 years. I started in 2001, so it was just soon after I came in, and we've worked together during that time. Overall, Bill has published over 260 peer-reviewed publications, 2 book chapters, 4 other peer-reviewed reports, and 3 not peer-reviewed reports. The echo went away. Can you still hear me?
Yes.
Okay. All right. That's great. Not just in breast cancer. He really is extraordinarily accomplished across many diseases as a statistician, many regarding ophthalmology, cardiology, vaccinations, and especially breast cancer screening with his partners at the University of Washington. He has an H-index of 71. which for those of you who don't follow academics and don't care about H indices, that's very high. It means he's quite accomplished, as we all know. And he's had more than 30,000 citations for papers he has authored. Next slide. Most importantly, he has published more than 60 peer-reviewed. Actually, go back a second. Go back a second, please. Go back to that slide. Last slide. More than 60 peer-reviewed papers related to SWOG. And I looked up, he and I have co-authored 45 or more papers. And that's just about as many papers as I've co-authored with anybody in my career. Bill has been a great collaborator. And again, an inspiration. Many of you may know other statisticians you've worked with. I have to say I've worked with some of the most well-known and best breast cancer biostatisticians in the world, including Don Barry, Rich Gelber, and Bill Barlow. And I put the three of them in the same bucket. And the reason why is not just because they worry about whether the hypothesis is likely to be null or that the p-value is 0.05. Bill, like his colleagues, has learned about breast cancer. He's learned about the disease. He understands the biology. He's one of us. He's not just an appendage to what we do. He is one of us and has been one of us for 20 years now. And for that, I give him lots of credit. Next slide. So he has published, along with us, of course, many high-tiered manuscripts, not just a bunch of them, in the New England Journal that have changed practice. Lajos has already referred to the one in Lancet with Kathy Albane, with Rita Mehta in SO226, and then, of course, with Kevin Kalinsky, also with Hallie Moore in regards to ovarian protection during chemotherapy. And then our most recent paper, Kevin Kalinsky, for the responder trial. And much of the design of that trial we owe to Bill Barlow. I don't think it would have happened if Bill hadn't been able to put that together in a way that was meaningful for everybody. Next slide. So I've shown this slide once before when I gave my swan song, but it just punch through the next slides, if you will. This is the leadership during the last 20 years ago in SWOG in general and the breast cancer committee, specifically when I started with Bob Livingston, the late Bob Livingston, who of course was also an inspiration, Gabriel Hortabaji, then replaced by Lajos and Priyanka. And I ran or was involved with the initially called the Biological Committee, then the Correlative of Science Committee, and then the Translational Medicine Committee. And now, of course, I've been more than ably replaced by our colleagues, Alistair and Andy. Most importantly, through all that period of time, though, with all these different leaders, Bill has been the concrete that held us together, the glue that kept us all in one committee, kept us rowing in the same direction, and was responsible for a lot of our success. And while lots of us say nice things about a lot of people, I cannot be more genuine in saying this about Bill Barlow. Next slide. So to sum this up, Bill, we've been congratulating you and feeding your many accomplishments all weekend. I'm sorry I'm not there in person to do it. I had to be back in Ann Arbor today, but congratulations on an unbelievable career, highly successful, and you've maintained your dignity and your friendships with us through all that period of time. You will be missed, you won't be forgotten, and you'll be long regarded and beloved by all of us who've had the opportunity to work with you. And I hope we can all keep in touch. Thank you, Lajos, for giving me an opportunity to say all this, and I will now sign off. Thanks a lot.
So thank you, Don. And Bill, thank you all what you have done. I also would like to take this opportunity to introduce you, Alison Meissner. Alison, if you are in the room, if you could stand up, Alison will step into the role of Bill. So we look forward to work with you, and Alison is fantastic. So we're gonna go back then to our agenda, and as always, we start with our scientific symposium. We have 3 outstanding speakers, and the theme is neoadjuvant therapy. And I think by the end of these 3 talks, you will understand why, but there are really a lot of really important things that are happening in the neoadjuvant, post-neoadjuvant space that are really paradigm shifts. and they are moving into the ER-positive space as well. So our first speaker, I'm delighted to introduce Fraser Simmons, my former colleague and a friend from MD Anderson Cancer Center, who is professor of pathology. And I think we developed together with Fraser, but with Fraser's leadership, a really fundamentally new concept how to measure pathological response. And Fraser is going to describe the implications of this for you. So Fraser.
Thank you very much, Laj. Thank you, Priyanka, and congratulations, Bill. I'm waiting for the slides, yes.
You talk so much about this, Fraser.
Click.
Slides.
I do. So, of course, you're all familiar with pathologic complete response. I'm going to speak more about residual disease. And these are my relevant disclosures. So in the modern era, finding the residual disease after neoadjuvant treatment can be particularly challenging. And even from observation alone, there are 3 primary tumors in the 3 slices of this mastectomy specimen prior to neoadjuvant chemotherapy, and none of them were easily found on gross examination. So when we think about quantifying residual disease and understanding its prognostic risk, as treatments get better and better and better, we're very much needing to focus on standardized approaches, and we're highly reliant on the quality of information from the multidisciplinary team, from the surgeons, the radiologists, and the medical record. So too, the residual histologic disease, once found, is also quite depleted many times, and this is not a particularly exaggerated example at all. And the disbursement and pattern of the residual invasive disease can be a little bit difficult to measure. And I think you can appreciate how definitions for stage versus just general extent of residual disease can sometimes be quite disparate. Noting this, the International Collaboration on Cancer Reporting published last year the first ever template for pathologists to evaluate specifically in the neoadjuvant setting, the first neoadjuvant template of any sort, and it is being adopted by many countries around the world. I was lucky enough to be part of this. And one of the key points of the required elements in the international template is that 2 measures of residual disease, stage and residual cancer burden, are to be reported side by side, which is one of the advantages of having a specific template for the post-neoadjuvant setting, is you can determine what it is you want and how you want it. And part of that reasoning, part of the evidence behind it, and this is just our published study on this topic, is that the 2 parameters are additive to each other. You can argue about statistical power in the stage 1 group, and you'd be right, but as the RCB categories shown as the Kaplan-Meier curves here are clearly adding something within this YP stage categories. Further evidence from a pooled analysis of just over 5,000 patients from multiple centers that has now been published, and a number of investigators from this group were involved in this study. And these were evaluations of the residual cancer burden locally at each center and then pooled together for analysis. So this is essentially their real-world experience. Left, we're showing the event-free survival, the event rate for EFS on the y-axis relative to the patients who had PCR. And it's on a log scale. And on the x-axis on these plots, we're showing the individual residual cancer burden index values. And then the vertical lines demonstrate the cutoffs between RCB1 and 2 and RCB2 and 3 categories. So what you see is a log linear relationship with risk. That's in the overall. And then, of course, the categories layer out on the Kaplan-Meier plot. And at right, we're showing the Kaplan-Meier plots for the 4 groups of breast cancer categorized by hormone receptor and HER2 status. And it's prognostic in each group. Focusing specifically in the hormone receptor negative, HER2 negative subgroup, you can appreciate where the real power of RCB will lie in the future, in my opinion. That's on the left. That's that log linear risk curve with tight confidence bounds around it. As we move towards having population-based data, we will really understand and be able to project and calibrate individual prognostic risk from national data. And that sort of continuous measure, just of residual disease, demonstrates how powerful the information is in pathologic response assessment and how informative neoadjuvant treatment is. Just for illustrative purposes, of course, you all know the CREATE-X trial, capecitabine versus placebo or control, and the positive result in triple-negative patients. 2 points. One is that wouldn't it have been great if we'd done a standardized pathologic evaluation of the RCB in that trial? Would we not be able to extrapolate and calibrate a patient's likely benefit from capecitabine versus control, watchful waiting, if we had done so? But we didn't. And there are several post-neoadjuvant placebo or controlled studies where we've lost the opportunity to do that, and we won't be going back to do placebo studies again. Secondly, the red arrow points to a Japanese-Korean methodology of estimating pathologic response, which I'll admit I actually didn't know about until I read this paper. And you can see that the benefit is in the effect grade 0, 1A, or 1B. In layman's terms, these are the subjects who had the most residual disease, the patients who had the lesser response. And I think sometimes sometimes people assume those numbers refer to RCB. They don't. It's actually the opposite, the inverse. In the HER2 positive subsets of the pooled analysis, again, by and large, and the numbers get small, especially in the hormone receptor negative subset where PCR rules, but there's still this log linear relationship, even in those two different subtypes. And then in the hormone receptor positive HER2 negative, you can see there's a clear relationship between residual cancer burden and the log of EFS risk, but there's a sway in the curve. You can appreciate that the 4 RCB classes are layering out prognostically meaningful way, and that the prognosis of PCR in blue and RCB1 in yellow are the same. That constitutes about 20% of sort of an all-comers population from this pooled analysis. So there are a lot of good responses in the hormone receptor positive HER2 negative, not all complete, but with the same prognosis as PCR. Now, why the bend in the curve? Well, we think that this analysis of the original MD Anderson cohort with long follow-up and the I-SPY trial, hormone receptor positive HER2 negative patients on the right with the unusual legend, showing that whether the subjects had RCB2, that's the yellow curve, or RCB3, that's the gray curve, that there's this, again, log linear relationship with risk, but this time with the added information of a prediction of stage-adjusted endocrine transcriptional activity. And the nuance there, it's not proof, but the nuance there is that that's capturing the subsequent adjuvant endocrine treatment, and that there's this additive relationship if you get a good response to the chemotherapy and you're able to respond further from the endocrine treatment to follow, that improves your prognosis compared to if you're less able to respond to the endocrine treatment that follows. And so that, think about it in terms of the two treatments are in sequence. There is not really a complex relationship of interaction between them. There is simply the additive effects on reduction in risk from independent treatments. In the I-SPY trial, with just under 1,000 patients, lesser follow-up, 5 years median follow-up. We can see on the left in panel A that there was this log linear relationship with RCB and EFS event rate in all comers. In the middle, panel B, we're looking at the subtypes, very similar to the pooled analysis. Of course, as you know, in I-SPY, the low-risk patients are excluded from the trial. And so really all of the 4 curves are all having that very similar relative association with risk. And notice that the triple negative and the hormone receptor positive HER2 negative, the gray and blue curves are almost identical. So in the relative sense, amongst luminal cancers, RCB is as prognostically meaningful as it is even in triple negative. It's just in a different context. And then on the panel on the right, I think very important from this analysis is that the randomized treatment arms are shown adjusted for hormone receptor and HER2 status and demonstrating that the control chemotherapy alone in gray or the experimental treatments that did not graduate from I-SPY trial in orange or the experimental treatments that did graduate from I-SPY based on very impressive PCR rates in the adaptive design are in blue. They're overlapping. And so what this really means for an endpoint in a neoadjuvant trial context is that it is relevant to all comers and it's less dependent necessarily on the individual treatment. It's not likely to change, and that if you see shifts in the population, that may well be meaningful information rather than just different treatment effects, at least for these chemotherapy-based treatment arms. And illustrating the frequency distributions of RCB from the I-SPY population, here's your 980 patients on one slide, you can see on the columns are the subtypes, they're labeled at the top, and the rows are the treatment arms. Control did not graduate, and investigational treatments that did graduate, that's on the bottom row. And you can appreciate in luminal cancers on the left that adding agents to chemotherapy didn't make much difference except for the glaring exception of pembrolizumab on the bottom left. You can appreciate in the triple negative and in the pooled HER2 positive populations that there's a huge difference between the control arm top and the graduating treatments on the bottom, but you can see those effects occurring to a lesser extent in those treatments that did not graduate but were investigational treatments shown in orange. So you can really start to garner some potential insights from the overall trial rather than just looking at a table of PCR rates. And we're hopeful that the continuous nature of the variable, once established, will be very powerful in neoadjuvant trials. Now, you might wonder, why is this not being used routinely? And it comes down, I think, to the logistics of implementation. In that, CRFs are often populated from pathology reports, and the work's already been done, and if it's not reported, it's not recorded, and it can't be analyzed. And I think that has been a challenge that we are hopefully going to be able to see a change in the near future. This is the College of American Pathologists' latest version of the invasive breast cancer synoptic report. It's in all of your breast cancer reports. And now it has the latest edition, adds in the residual cancer burden if the patient has had post-neoadjuvant evaluation. This is required by March 2024. It was issued just a couple of months ago in June. And these are the elements, how they will be recorded in the synoptic report. There's this nefarious comment that says, for institutions that wish to report treatment effect using the RCB calculator, I suspect that's a reference to some groups of pathologists thinking, well, maybe our doctors don't want it. And I would suggest that if you do, or if you're in a trial site that collects this information in their neoadjuvant trials, that you get on the phone and talk to your pathologists and say, well, now it needs to be reported if we want it, and we want it. That's if you do. Okay, so to conclude, response to neoadjuvant chemotherapy is prognostic in every subtype, and standardized methods for specimen evaluation and reporting is very important. There's strong potential to be able to estimate an individual's residual prognostic risk from their RCB. It's generally linear relationship, or log linear relationship. This can further the interpretation of response results from randomized trials, and in the goodness of time from high quality population databases, we will begin to be able to calibrate patient-specific risk. And then finally, RCB is becoming a standard of care. Both stage and RCB are now included in the CAP synoptic report. Do inform your pathology colleagues if you want that in your reports. Thank you very much.
We will hold questions till the end. Our next speaker is Dr. Erin Cobain, who's Assistant Professor in Department of Internal Medicine at Rogel Cancer Center, Michigan, and she will talk to us about neoadjuvant chemoimmunotherapy for hormone-positive breast cancer, patient selection, and trial endpoints.
So while Erin is getting up her slides, I just want you to keep that slide in mind that Fraser actually showed, that the RCB only tells half of the story about a prognosis. So the other half for ER-positive patients is in the SET component, the sensitivity to endocrine therapy, right? So you can have an RCB 3, but still your risk of recurrence is low if your SET is high. That's what this very complicated picture that Fraser actually showed. And I think that's a very good segue for Erin to present the trial.
Wonderful. Good afternoon, everyone. Very happy to talk this afternoon about neoadjuvant chemoimmunotherapy, specifically for hormone receptor positive, HER2 negative breast cancer. And at the end, I'm really going to tie this into a SWOG trial that we will soon have open and hopefully accruing. So just to start us off, I want to begin by discussing the current state of neoadjuvant systemic therapy in hormone receptor positive, HER2 negative early stage breast cancer. I think we're all aware that the options that we have at the moment include the potential to give neoadjuvant chemotherapy as well as neoadjuvant endocrine therapy. But unlike in triple negative and HER2 positive early stage breast cancer, administration of neoadjuvant systemic therapy for hormone receptor positive disease really has not been fully adopted as standard of care. And the question is why? So historically, the rates of pathologic complete response are low to both chemotherapy and endocrine therapy, and we'll show a little bit of that data in a moment. And so therefore, it's maybe a little bit less likely that a patient's surgical treatment can be de-intensified after that neoadjuvant systemic therapy. And also, at present, at least, the response to neoadjuvant systemic therapy does not impact our recommendations for adjuvant systemic therapy. So this is, of course, in contrast in triple negative disease, where those with residual disease go on to get capecitabine, those that have a path CR do not. And in HER2 positive disease, we're giving adjuvant TDM1 to those with residual disease versus continuing Herceptin Perjeta for those who have path CR. So neoadjuvant endocrine therapy for hormone receptor positive disease, I've just shown some of the data that I think many of us are very familiar with. Looking on the left-hand side first on neoadjuvant tamoxifen versus aromatase inhibitor. Just want to make the point that aromatase inhibitor is slightly superior to tamoxifen in terms of rates of pathologic complete response, but you can see here that overall response and rates of pathologic complete response, even with our optimal endocrine therapies, are still quite low. And then if we compare neoadjuvant endocrine therapy versus chemotherapy across many studies, we can see that there's a little bit of a favor toward benefit of neoadjuvant chemotherapy over endocrine therapy in terms of response. But again, rates of pathologic complete response are relatively low. And I've highlighted here specifically response rates to neoadjuvant chemotherapy in hormone receptor positive disease. You can see they've separated this out by those that are grade 1, 2, or grade 3 disease. For those that have grade 1 or grade 2 cancers, the pathologic complete response rate to neoadjuvant chemotherapy is about 7.5%. For individuals that have a grade 3 tumor, a little bit higher at 16%. But again, these do not come anywhere close to what we see in the more 50, 60, 70% pathologic complete response rates observed for triple negative and HER2 positive disease. This was already mentioned, of course, by Dr. Simmons, so I won't spend too long here except to say that pathologic complete response does indeed correspond with improvement in event-free survival. So here in the red curves, or the red portion of the Kaplan-Meier are those that achieved path-CR. The blue are those that had residual disease, all comers, and then again separated out by grade 1, 2 versus grade 3 disease. And you can see, of course, that those who had path-CR do indeed have improvement in event-free survival. So one of our challenges here, I think, is that hormone receptor positive HER2 negative breast cancer is an incredibly heterogeneous disease. And I want to highlight just a few clinical examples that illustrate this. I think we're all very familiar in the clinic that we have very different patterns of recurrence for patients with hormone receptor positive disease. This is, of course, the publication by Dan Hayes and others demonstrating that, some patients with hormone receptor positive disease may have a recurrence that happens within the first 5 years of their diagnosis, whereas we can also see these patterns of recurrence 20 years out from their original breast cancer diagnosis. And these are really completely different paradigms. We've also seen chemotherapy benefit differences in, of course, pre versus postmenopausal patients. This is from the responder trial in those with 1 to 3 positive nodes, where we see postmenopausal patients with a recurrence score of 25 or less indeed do not benefit from chemotherapy. However, in premenopausal patients with 1 to 3 positive nodes, regardless of Oncotype DX recurrence score, there is indeed a chemotherapy benefit. Again, comparing patients that are younger at diagnosis versus older at diagnosis, we see really also these differential patterns in estrogen receptor and immune-related gene expression. You can see that in younger patients, there tends to be less estrogen receptor-related gene expression, perhaps more actually immune signature-related upregulation, such as B-cell and T-cell signatures, although proliferation-related genes appear to be relatively similar in younger versus older patients. And then finally, the degree of immune infiltration in hormone receptor positive HER2 negative breast cancer. I think we now understand that this predicts chemotherapy sensitivity. We're going to talk a little bit about in a moment how this also can play into potentially immunotherapy sensitivity. But again, just highlighting that in particularly hormone receptor positive HER2 negative disease, there's really a wide range. There are tumors, about 20% of which have, very low to no lymphocyte. Some of them have some lymphocytic infiltrate. And then, of course, there's this small percentage that are lymphocyte predominant. And those indeed have highest rates of pathologic complete response to chemotherapy in the range of about 23%. So the question now is, are there hormone receptor positive HER2 negative early stage breast cancer patients that may actually benefit from the combination of chemotherapy and immunotherapy? And I want to talk about 2 trials that have now completed accrual and are set to be presented at ESMO just about a week and a half from now. The first is the Keynote 756 trial, which took patients with hormone receptor positive HER2 negative disease. Want to highlight that in addition to the anatomic inclusion criteria that you see listed there, all of these patients included in this clinical trial had to have a grade 3 tumor. And they were randomized to ACT chemotherapy with pembrolizumab versus ACT chemotherapy with placebo. Following their surgical treatment and other local therapy, patients then received investigator's choice endocrine therapy, and those that were assigned to the immunotherapy arm went on to continue the pembrolizumab for an additional 9 cycles, or placebo for those that did not get assigned to the immunotherapy arm. There are co-primary endpoints to this trial, so both pathologic complete response as well as event-free survival. And then there is the Checkmate 7FL study, which has very similar inclusion criteria, except they allowed for grade 3 tumors or those that were grade 2 with ER 1 to 10%. And again, patients randomized to chemoimmunotherapy. This time the immunotherapy is nivolumab versus ACT chemotherapy with placebo. And then again, similarly, an adjuvant IO component, very similar to the Keynote 756. This study has a primary endpoint only of pathologic complete response. So we know that both of these are late-breaking abstracts to be presented at ESMO 2023. We did see the Merck press release July the 28th, indicating that pembrolizumab plus chemotherapy before surgery significantly improved pathologic complete response rates compared to neoadjuvant placebo plus chemotherapy. But I think there's some important considerations that we need to take into account as we interpret these results and ultimately see the data. First is, of course, the study inclusion criteria. It included patients with high clinical risk disease, but did not really biomarker select patients based on additional tumor features that are known to be associated particularly with IO benefit. Only the pathologic complete response data is available at present, and we know that reporting of event-free survival will certainly take additional time. Also, none of the patients in Keynote 756 or Checkmate 7FL received an adjuvant CDK4/6 inhibitor and a treatment that has now become standard of care for high clinical risk patients in this disease setting. And also, Keynote 756 and Checkmate 7FL both included an adjuvant IO component. So I want to transition now again to talking a little bit about I-SPY 2, which has already been referenced, and to mention that really the retrospective analysis has identified this subset of hormone receptor positive breast cancer patients, specifically those that by MammaPrint are designated as MP2, meaning that they're sort of the highest end of the MammaPrint risk category, that are not only highly chemotherapy sensitive, but may benefit also from immunotherapy treatment. Here we can see that individuals who are this MP2 designation by the MammaPrint category have markedly improved pathologic complete response rates when immunotherapy is added to the chemotherapy backbone. And that is contrasted with those that are MP1, which are still high risk, but the lower end of that high risk category, where you do not see that shift to improvement in pathologic complete response when immunotherapy is added to the chemo backbone. We also know that there are molecular differences between these MP1 and MP2 hormone receptor positive breast cancers. There is lower estrogen-related gene expression in the MP2 cancers. There is higher proliferation signatures and also higher degree of immune signatures. Many people have asked about this question of, as we've been exploring this biomarker MP2 and potentially as a predictor of immunotherapy benefit, what is the overlap of this with some of the other sort of high-risk clinical features like were included in Keynote 756 and Checkmate 7FL, so specifically recurrence score greater than 25 as well as tumor grade. And Dr. Gregory Vidal, who's not here this afternoon, but was here earlier in the meeting, was kind enough to share this slide with me. This is data that'll be presented by him and colleagues at San Antonio, so this is unpublished data. But what you can see here is that in the left-hand side, those that are MP2 are not all recurrence score greater than 25. Of course, the majority of them are, but there are some with recurrence score less than 25. And also, as we look across grade, although the MP2 cancers are, small numbers in this data set, there are some that are indeed grade 2, which, makes us think that perhaps if we're looking at things like grade alone, we would potentially be missing patients that could benefit from immunotherapy. So we think that MammaPrint high 2 status is potentially a more accurate way to identify hormone receptor positive patients who may benefit from neoadjuvant IO therapy. And this is really the impetus for the S2206 clinical trial, which we are hoping will activate by the end of October. This is a trial that currently has approval on hold by CTEP, and we've just submitted the minor protocol revisions that have been requested. And this study will use the MammaPrint high 2 status to select patients for treatment with chemoimmunotherapy. They will be randomized to neoadjuvant ACT versus neoadjuvant ACT plus plus durvalumab. And we're going to talk a little bit more about the logistics of this trial later on in the meeting. But again, I just wanted to show the schema and make the point that, of course, the MammaPrint assay really is the integral biomarker here because of the really compelling preliminary data from I-SPY 2. So again, just to wrap up with some thoughts about trial endpoint considerations and patient selection considerations for these trials, event-free survival and invasive disease-free survival, I think, are still the most important trial endpoints as we consider doing studies that include an IO component for this disease setting. I think we have really strong indication that pathologic complete response, and as we've heard about earlier, residual cancer burden correlates with improvement in event-free survival if these are favorable. But it hasn't been completely validated, particularly as rates of path-CR for this disease setting have historically been quite low. And I think that event-free survival data remains important. And it is also important to better understand if biomarker selection beyond clinical high risk can help better define which patients with hormone receptor positive, HER2 negative breast cancer benefit from IO therapy. I think we really have to remember that giving immunotherapy is not benign. There are many patients that have really significant side effects from immunotherapy. And so one of the concerns I think many of us have is that if we're using only clinical high-risk features and not necessarily biomarkers that we know that are predictive of immunotherapy benefit, that we run the risk of over-treating patients who may ultimately have adverse consequences from immunotherapy. So that's my last slide, and I thank you all very much.
Thank you, Erin. Our last speaker for the symposium is Dr. Zahi Mithri, who is an associate professor of medicine in Department of Medicine at British Columbia Cancer Agency, Vancouver. And Dr. Mithri will talk to us about neo and adjuvant chemoimmunotherapy for triple-negative breast cancer, right-sizing the treatment.
Way too far forward on the slides. Thank you, everyone, and thanks for the opportunity to, to speak today about neo and adjuvant chemoimmunotherapy regimens for triple-negative breast cancer. They're my disclosures, and just to focus today, we're going to be actually talking about patients for whom you would consider neoadjuvant kind of chemoimmunotherapy, and we're not going to be discussing the lower risk T1A, T1B, who usually are treated with upfront surgery. And to start us off, we're going to talk about some multi-agent chemotherapy, because one of the things we want to talk about today is which is the best chemotherapy, or how do we identify the best chemotherapy backbone to combine with chemoimmunotherapy moving forward. And one of the trials that we want to talk about first is the Brightness trial. And the Brightness trial looked to answer the question of if we add to a backbone of paclitaxel and AC carboplatin, or a combination of carboplatin and the PARP inhibitor veliparib, can we actually improve pathologic complete response and then event-free survival in patients with locally advanced triple-negative breast cancer? And in this study, about 40% of patients had node-positive disease, and the majority had T2 or larger tumors. And in the initial evaluation for the PCR and the RCB01, which you've heard about today, the addition of carboplatin to a backbone of paclitaxel and AC did significantly improve the pathologic complete response as well as the RCB01 rates for these patients. Of note, the combination of veliparib and carboplatin did not show any added benefit compared to carboplatin alone in the setting. And one of the main things in the study is that this improvement in PCR and RCB did translate into an improvement in event-free survival. And at the 4-year mark, we did see about a 10% improvement for both carboplatin-containing arms compared to the paclitaxel followed by AC arm. And this really solidified kind of one of the roles of carboplatin is a neoadjuvant therapy in our multi-agent chemotherapy backbones. So the question becomes, well, if carboplatin is adding benefit to the PCR, which we've seen in several trials, and then translate into EFS, can we actually compare a platinum-based therapy to the paclitaxel followed by AC therapy? And the NeoStop trial actually tried to first compare two multi-agent regimens. One of them is paclitaxel carboplatin followed by AC compared to an anthracycline-free carboplatin and docetaxel regimen. And in this study, it showed that the RCB01 and the PCR rates between the two regimens were equivalent. But when you looked at the safety, the anthracycline-free regimen was better tolerated with less grade 3 to 4 AEs. Of course, when all of this was happening, Keynote 522 was ongoing and set the new kind of standard of care chemoimmunotherapy for locally advanced triple-negative breast cancer. And in Keynote 522, patients with locally advanced triple-negative breast cancer were randomized to receive a backbone of chemotherapy consisting of carboplatin paclitaxel followed by anthracycline and cyclophosphamide. And in one group received neoadjuvant as well as adjuvant pembrolizumab, the PD-1 inhibitor, versus the other group received placebo. And the primary endpoints of the study were PCR and event-free survival. And what this showed is that the addition of pembrolizumab to this backbone of chemotherapy did first improve the pathologic complete response rate from about 51 to 65%, and that did translate into an improvement in EFS, which led to the approval of the Keynote 522 regimen as a standard of care neoadjuvant chemoimmunotherapy for locally advanced triple-negative breast cancer. Now, in the metastatic setting, we use PD-L1 to select patients for immune checkpoint inhibition. So this marker was looked at in the neoadjuvant setting to see if we would be able to identify a population that would benefit more from the addition of pembrolizumab. And the reality is that we were not able to find that PD-L1 selected for patients to benefit more regardless of the level of infiltration. So in this setting, we do not choose PD-L1 as a marker to select patients for neoadjuvant therapy or chemoimmunotherapy. What about safety? Every time we add new drugs, we risk adding more toxicity to our patients. And in this setting, we did see an increase in treatment-related adverse events, most of it driven by immune-related adverse events that are expected in the pembrolizumab arm versus the chemotherapy arm. But what we also saw is that there was a high rate of treatment discontinuation, almost 27% compared to 14% in the chemotherapy arm. So again, this is not an easy regimen with 4 chemotherapy backbones. Around the same time, the GEPAR-NUEVO trial was asking a bit of a different question about adding neoadjuvant immunotherapy with the PD-L1 inhibitor durvalumab to a backbone of chemotherapy. In this study, the patients did not receive adjuvant immune checkpoint inhibition. And despite not having a significant improvement in the pathologic complete response rate, this actually did show that the patients who did receive durvalumab in the neoadjuvant setting had better survival, including distant disease and overall survival when followed. So this kind of puts in perspective that immune checkpoint inhibition became standard as well in our treatment of locally advanced triple-negative breast cancer. So now that we know that basically one of the standards is chemoimmunotherapy, and we've looked at multi-agent chemos, we've noticed also that, again, the Keynote regimen is an effective one, but it's adding quite a bit of toxicity to our patients. And the NeoStop trial comparing really the similar backbone from Keynote 522 to carboplatin and docetaxel yielded, as multi-agent chemotherapy comparison, similar PCR and RCB rates. So in the era of chemoimmunotherapy, can we actually get away with using a less intensive chemotherapy combined with immune checkpoint inhibition and achieve the same benefit for our patients? And the first study to try to address that in this kind of de-escalated or optimized regimen was the NeoPAC trial led by Dr. Sharma. And the NeoPAC trial looked at basically a regimen of carboplatin, docetaxel, and pembrolizumab given for 6 cycles before surgery, and patients did not receive adjuvant pembrolizumab on this study. And what it showed is that with this regimen, you're able to achieve almost a 60% PCR rate and a 69% RCB 0 and 1 rate. And as we see in the event-free survival curves, patients who achieve a PCR, as we've heard today, have excellent prognosis, but overall, the recurrence-free at 2 years was 89% in the entire cohort, again, without adjuvant pembrolizumab. Safety-wise, the regimen was fairly well tolerated and was fairly similar to the NeoStop, except for the immune-related adverse events, but a much lower rate of treatment discontinuation, again, allowing for cross-trial comparison. Didn't look at PD-L1 this time, but looking at tumor-infiltrating lymphocytes, these have been predicted actually that have been a predictive biomarker for improved pathologic complete response. And in this setting, in patients who had tumors enriched for stromal TILs at more than 30%, there was a much higher rate of pathologic complete response at almost 76% compared to 41% for tumors who had less than 30% tumor-infiltrating lymphocytes. So all of that really sets the stage for a trial that basically is led by Dr. Sharma through SWOG and just opened in July of this year, which is the SCARLET trial. And the SCARLET trial is really trying to ask the question that in the era of chemoimmunotherapy, can we use a platinum taxane chemoimmunotherapy regimen and show that it's non-inferior to a platinum taxane anthracycline chemoimmunotherapy regimen? So 2,400 participants will be randomized between the keynote regimen and the neopact regimen of docetaxel, carboplatin, pembrolizumab. Following neoadjuvant therapy, patients will go to surgery, and the adjuvant treatment is really per the investigator discretion, meaning in patients who have residual disease on the anthracycline-free arm, for example, they can get anthracycline in the adjuvant setting. Patients with germline BRCA tumors can get adjuvant olaparib. And we'll talk a little bit also about the patients who achieve a PCR. The primary endpoint of the trial is breast cancer event-free survival. Stromal TILs are an integral biomarker, and they will be evaluated throughout the study and by teams led by Dr. Rim and Dr. Salgado. And again, we are going to we have built-in patient-reported outcomes in this study, and it's really important to be able to actually have a comparison of quality of life and toxicity of these two regimens in one trial, because if these regimens end up being actually of equal efficacy, patient-reported outcomes will be very important in determining selection of therapy. So what do we do post-neoadjuvant therapy? Really, one of the best news we tell our patients, well, you've achieved a pathologic complete response, but then we tell them you're going to get another kind of 6 to 9 months of immunotherapy still. So do we need to do that in patients to achieve a PCR? Do we need to give further actually adjuvant immune checkpoint inhibition? And the Keynote 522 PCR arms, and this is buried in the supplement, it showed that actually both the chemo and the chemoimmunotherapy arms in patients who achieve a PCR have excellent outcomes. So Dr. Tolani is leading the optimized PCR trial, who's trying to answer the question that in patients who receive neoadjuvant chemoimmunotherapy and achieve a PCR, do we need to give more adjuvant pembrolizumab? So patients will be randomized to either an additional 27 weeks of pembrolizumab or observation, and this trial also activated earlier this year. What about post-neoadjuvant therapy for residual disease? And the standard of care here is really per the CREATE-X. We give most of our patients capecitabine. We do continue the pembrolizumab. And in patients with germline BRCA mutations, we are giving adjuvant PARP inhibitor with olaparib. There are some studies we're waiting on data from. The SWOG S1418 trial will try to give us a bit more information on the benefit of pembrolizumab in patients with residual disease. That being said, to neoadjuvant chemotherapy, because patients did not get chemoimmunotherapy in the neoadjuvant setting in that study. The SASIA trial is looking at high-risk hormone-positive and triple-negative breast cancers with residual disease and trying to find the benefit from the TROP2 antibody-drug conjugate sacituzumab govitecan. And there are two trials in the adjuvant and neoadjuvant setting looking at the PD-L1 inhibitor atezolizumab to try and define the role in this setting as well. Some ongoing trials include TROPION-Breast03, which is looking at in patients with triple-negative breast cancer who have residual disease following neoadjuvant therapy, randomizing them to the TROP2 antibody-drug conjugate Dato-DXd either alone or in combination with an immune checkpoint inhibitor versus treatment of physician choice. And the ASCENT-05 trial will look at comparing in patients with residual disease sacituzumab govitecan to treatment of physician choice. And last but not least, I think that we're having really faster and faster development of our biomarkers. And we have ctDNA that's kind of made it in some parts in the clinic. I don't know if everyone's using it or not. But what we're seeing more and more that these biomarkers can be helpful in actually prognostication, especially post-residual disease. And there are several studies that have reported that even in patients with residual disease following neoadjuvant therapy, if they have a negative ctDNA, they do have excellent prognosis. So I wonder if moving forward as we design these studies and we try to escalate or de-escalate therapy for patients with residual disease, if we need to integrate some of these markers in so we don't add toxicity to some patients, but also maximize the benefit to patients who are at higher risk of disease. And that's all I said. Thank you.
Thank you. I would like to invite all our three speakers up on the stage for question and answer session. Apparently, we don't have enough chairs. We will share. As long as the IT is working, we can make the chairs work. Okay, so this symposium is open to questions. As folks are coming up to the microphone, if I may ask Erin, the two big pharma trials included an arbitrary year of immunotherapy, and that's one thing we're already struggling with triple-negative breast cancer, designing trials to see what we can scale back. Do you have any thoughts about the SWOG study, stopping the immunotherapy at the neoadjuvant juncture versus continuing? Any thoughts on that?
Yeah, I mean, I think the one thought that I would add is just a logistical one, which is that now that we have adjuvant CDK4/6 inhibitors approved, currently only abemaciclib approved. It is actually not advisable to give concurrent abemaciclib and immunotherapy because of the increased rates of pneumonitis that are seen. So now that we have a CDK4/6 inhibitor approved in that space, if we were practically going to give an adjuvant IO component, I think it would probably mean not an adjuvant CDK4/6 inhibitor component. And so that's sort of another question that needs to be addressed, is this notion of, what component is actually benefiting patients the most. So in our trial, that's one of the reasons we chose not to include the adjuvant IO component, under the assumption that the vast majority will get adjuvant CDK4/6, and then we'll hopefully be able to learn more.
So if 756 leads to an FDA approval, it will lead to an approval of the whole regimen, where we really won't be able to deliver the second part of it, because most of us would choose a CDK4/6 inhibitor. So that would leave us in a pretty big clinical conundrum.
Okay. Great talks. Dr. Mitre, could you clarify? It looked as if the patients who don't get a complete pathologic response on Scarlet could go into the Alliance trial, but not Tropion-3?
Yeah. So patients who get a pathologic complete response can co-enroll between Scarlet and the Alliance trial. They need to achieve a PCR, because the Alliance trial is focused only on the PCR patients. But in patients who do not achieve a PCR, we have not made any kind of restrictions or recommendations in the protocol on their adjuvant therapy. We understand patients may actually be able to enroll in other studies, and we don't want to limit that.
So there'll be a trial really for all of those circumstances, with
Right.
and without. Thank you.
Yeah, so for those with residual disease, the protocol doesn't restrict enrollment in other trials, whether it's Tropion, ADC, or some patients will go on other lifestyle intervention trials too that have disease-related outcomes.
Just to add a little bit to this, we actually would like them to go on Tropion Breast 03. So they are totally eligible for it, and we would like you to put them on the study.
Most of us have both open. We're opening Scarlet, and we already had Tropion open. Yep. So, Fraser, if I may ask, in my optimistic view, if we will see RCB part of our routine pathology reporting, once that information is available over the next 2 or 3 years from our clinical databases, what do you foresee our next steps should be? What should we do with that information, besides clinicians using it to care for their patients?
Well, thank you, Priyanka. So I think the answer is probably yes to the first question. The CAP synoptic reports a requirement for your CLIA license, and they're also a requirement for the American College of Surgeons evaluations. So people have to do it, and it may take time, but I think it will inevitably happen. I think and I alluded to this in my talk, the lost opportunity is that the plethora of post-neoadjuvant residual disease trials in any of the subtypes, but particularly triple negative, are not requiring RCB evaluation in those trials. And so it is, although it costs nothing because it's just part of the pathology report, it is really a lost opportunity, because you see that tight log linear relationship with long-term outcomes. And you say, why would you not want to factor that in to the decision of not only whether to give a post-neoadjuvant treatment to someone with residual triple negative, of course you're going to, but which ones? Which ones are most effective when? And if you're going to do expensive ctDNA monitoring of your patient for an indefinite period of time, when? If you had a really great response, do you start in 6 months or do you start in 3 years? These are all critical questions, which I think we have to get as much information, not the minimum amount of information, from these randomized trials so that we can piece it together in the future. That's my comment.
Dr. Budd?
Yes, all great talks. I really appreciate it. I have a question for Dr. Simmons. Showing the SET2/3 index, adding information, was that done before or after neoadjuvant treatment? And does the change with adjuvant treatment add any information?
Thanks, Tom. It was all done before neoadjuvant treatment. We really don't have data from the after treatment. So, for example, we've not looked at Penelope B or any studies like that. And we don't know yet from peer comparisons whether it changes, which would preempt the biomarkers, when should you test it, which sample. So still to be learned. We have just completed analysing 3,500 results passed from the PALACE trial. So some of these subsets, these real-world subsets, will be represented in the PALACE, and we hope to learn quite a lot more from those secondary studies.
Thank you.
So thank you for very nice talks, all three of you, and timely with trials activating, perhaps cap changing. And we'll move on to our next section. Oh, there's a chat question. Thank you for monitoring that.
So there was a question in the chat. Any thought for S2206, where including CDK4/6 inhibitor, and also could you comment on the use of PARP in the high-risk populations with hormone receptor positive disease? So I think I mentioned the concern about combining CDK4. Any thought about including CDK4/6? Well, so we assume that most of the patients in S2206 will get adjuvant CDK4/6. As I mentioned earlier, I think the concern is that if you were to do adjuvant IO and adjuvant CDK4/6, there may be significantly increased toxicity. And so that's a major concern. And then PARP inhibitor for individuals that are germline BRCA mutation is allowed in S2206. So if you have somebody with a BRCA1 or a BRCA2 mutation and you were to choose to give them an adjuvant PARP inhibitor, instead of an adjuvant CDK4/6, it's completely fine. The idea with S2206 is actually that all of the adjuvant systemic therapy is at the investigator's discretion. So it is not mandated by protocol.
Thank you. Thank you so much. Yes. We'll move on to our next section, which is a publication update by Dr. Barlow.
You can see. Oh, I see. Just control it from there. Okay. Be closer. So this publication was impressed at the last meeting, so it's now out. It's from SO800, looking at TILs and predicting pathologic complete response. Let's see, I went too far. Okay. Is that the second slide? Okay. This one also was impressed from Dr. Jagsy, looking at radiotherapy use and incidence of local regional recurrence in patients in the responder trial. It's now at JAMA Oncology. This is a paper from Dr. Hertz's group. He's actually very busy, as you will see that there are several publications from Dr. Hertz here, looking at CYP3A4 and CYP2C9 genotypes in our 0226 trial. This one was looking at adherence to cancer prevention guidelines before, during, and after treatment. So that was from the survey about exercise and alcohol and various other aspects in the survey, and saying how is adherence affected by actual treatment and what happens during and after treatment. So this paper is actually from the Oxford overview. So S0221 was included in the overview. I think approximately 6,000 patients from us, and you can see that there were 100,000 patients overall in 86 randomized trials. So an incredible data collection effort on part of the overview group. Also from Dr. Hertz's group, looking at vitamin D insufficiency as a peripheral neuropathy risk factor. It's in white and black patients, and it has been accepted. We're no longer allowed to tell you what journal until it actually comes out. Another one that's been accepted from Shane Steckline, looking at triple negative breast cancer, looking at DNA damage immune response and homologous recombination deficiency together. How do the combination of those two factors affect survival? And that has been accepted. This one is an interesting one. So this is not published yet, but it is listed in PubMed because PubMed is trying something new, which is to take manuscripts and assign them an identifier and make them available even before it's been submitted to a journal. So it now appears as a manuscript, and I believe it's been submitted recently to an actual journal. And there are two manuscripts in preparation. This is one of them where we have a manuscript that's currently circulating among the authors from Yara Abdu, looking at race and clinical outcomes. In Responder, this was presented at San Antonio last December. And another one that was presented at San Antonio last December from Dr. Chavez McGregor. It's the primary results from S1207. The manuscript has gone through a couple revisions already and will likely be submitted soon as well. I think that's it.
Thank you, Bill. Looks like the committee has been very busy with Bill's help. You see he's on almost all of them. So, Allison, we look forward to similar update from you at the next meeting. Our next section is update from our patient advocates, Ginny and Roberta. It's up to you.
Hi, I'm Jenny Mason, one of the two patient advocates on our committee. I serve along with Roberta. Thank you. This slide just shows some of the things we're both involved in. I won't go through all of these. You can read. It always annoys me when people read their slide word for word. We are involved in a lot of different things. A few of the things I wanted to bring up about my own work with both SWOG and beyond. We are starting on a 5-year DoD grant that will be reviewing materials with both RxPonder and TaylorX. We've just had one meeting so far since the funding was announced. So I'm not really sure what all of our responsibilities on the steering committee are going to be, other than we have lots of things to sort through, educational materials to develop and things like that. So we meet again when I get home on Monday, so I'll know a little more about what that's going to take. I'm also really excited to be very involved in the global advanced breast cancer community, and we'll be in Portugal at the Advanced Breast Cancer Conference next month. I'm on the Advocacy Planning Committee and as a member of the New Global Charter Working Group, looking at the state of advanced breast cancer from a global perspective and where we need to be doing work. And I thank you for the inclusion of advocates on the breast committee and in SWOG in particular. And you need to know that the patient advocacy committee is going through some growing pains, as you heard during this afternoon's plenary session. Starting Monday, we have new leadership with Barbara and Anne-Marie. And Rick and Hildy will still be around giving us some guidance. They've been very good at helping our new folks get their feet wet. And we have community advocates as well, which you may not be as aware of. I'd encourage you to check out the SWOG website to learn more about the folks that we have. We still have some vacancies because we've had a few people have to leave, but we have someone representing Veterans Affairs. We have the LGBTQ plus advocate, someone for adults, young adult survivors. So we really need to make sure we include them when we're looking at our clinical trial development if there are particular populations we're focused on, and make use of these community advocates. They've got lots to bring to us.
Good afternoon. I'm Roberta Albany. I'm gonna do like Jenny did. You can see I'm still involved with all the things that's on the slide there. But outside of that, I have written an article about how to build trust in clinical research in communities of color back in June of this year. I also attended the DIA conference in June, and I spoke on that panel regarding clinical trials and marginalized populations. I will be attending the conference in Canada, speaking about DEI, how we can get more marginalized populations into clinical trial next month. I shared my experience in San Diego at the Astro conference, talking about my experience participating in a clinical trial for radiation. And I'm also will be doing, attending the FDA CTTI conference in November for a public workshop about community engagement and speaking about getting more marginalized populations into clinical research. Thank you.
Thank you, Roberta and Jenny, for supporting our many ideas, providing us constructive feedback early on in the course, and once the trials are up and running, to advertise the trials and make sure that the patient community is engaged. So we appreciate all you do. Our next section is Translational Medicine Subcommittee Update. Dr. Thompson and Godwin.
Thanks, Priyanka. Very briefly, we had a great translational medicine meeting yesterday, and I would say in the future, anyone who's interested in coming to that, please just let us know. We welcome anybody and everybody who's interested. Some of the things we're trying to do a little bit differently are, instead of having the trial run, trial finishes, and then we twiddle our thumbs a bit and think about what are we going to do to collect the specimens in, etc. I'm exaggerating. We're trying to bring forward to an earlier stage that we do some of the translational work while the trial is getting going. And I think 1706 is a very fine example of that, where Corey Spears and Reshma Jagsmi and others are working together to try and get some preliminary data while the trial is halfway accrued. The second thing we're trying to do is get other elements of translational medicine up and running, particularly the imaging side of things. And Julia McGuinness was really driving that very effectively yesterday. So we look forward to some more happening there. And then finally, we're about to restart our once every couple of weeks meetings, which Alicia will coordinate, myself and Andy Godwin, who's sitting here as the vice chair of the Translational Medicine Group, used to meet. And we'll miss you a lot, Bill, but we're going to be delighted to be meeting with Alison in order to try and support, help move forwards all the translational medicine sub-studies of all the trials we're doing. I think I've covered everything, Andy. Anything else to add? No, we're good. Thank you so much.
Thank you, Alistair. It was a great meeting yesterday, and lots of projects that are ongoing, and many others are in discussion. So those that are interested, please reach out to Alistair and Andy. It's a very welcoming group. Many projects have junior investigators that are part of it, and it's a great opportunity to receive mentorship. So our next section is review of our open CTSU and SWOG CTP trials. And in this section, we go through each one of our open studies. Some are brief, some are a little bit longer if they have new updates to share. And I'll get that started with Scarlet 20-12, since this is one of our recently activated studies. My co-chairs for the study are Zahi Mithri and David Rim, and quality of life study chairs are Michelle Locke and Lynn Henry. You've seen this design. It's a simple randomized phase 3 trial and does not require any tissue submission or assessment before patients are randomized. Most patients with early stage triple negative breast cancer who are eligible to receive chemoimmunotherapy would be eligible for the trial, with the exception of those that have higher clinical stage. So patients with N3 disease, inflammatory breast cancer, or T4 disease are not eligible, as we felt that de-escalation may not be appropriate for these patients. So these are eligibility criteria. The triple negative goes up to an ER of 5, ER and PR of 5%. So patients with low degree of ER, PR positivity are eligible as long as there is no intention to give adjuvant endocrine therapy. Participants who have clinically suspicious nodes must have pathological confirmation of node-positive disease with either a core needle biopsy or fine needle aspiration. Routine breast and axillary imaging is required prior to enrollment. Patients who have bilateral breast cancer are eligible as long as both cancers are triple negative and meet the stage requirement for study entry. TIL assessment is integral to the trial, but tissue submission is not required prior to registration or randomization. Patients can register and randomize. The H&E slide can be submitted once they're registered. And the required submission is one H&E slide for TIL assessment. There's optional tissue submission from the core needle biopsy in terms of slides. So 579 sites applied to be part of the study. Thus far, 334 sites have been approved. 136 have activated the study. We had our first enrollment just about a month ago, and the current enrollment as of last week was 4. I want to see with show of hands how many sites have the trial open or are planning to open, even if you don't have it open yet. And those that didn't raise their hands are not in this field or have other competing studies. How many have competing studies? Then I would assume that those that didn't raise their hands are not the decision makers to open the trials. I just want to bring up a few things that have come up already in the last 4 weeks as sites were activating the trial in terms of questions about schedule. The first one that came up was about carboplatin schedule. Arm 1, which is the Keynote 522, allows both weekly or every 3-week schedule. Arm 2, which is docetaxel and carboplatin, does not allow the 3-week schedule because it's an 18 weeks treatment, and 18 weeks of weekly carboplatin would be prohibitive with the risk of hypersensitivity. That risk goes up quite dramatically after the 11th or 12th dose. So hence that arm is only every 3-week carboplatin. A similar question came up about paclitaxel. So that's in the Arm A, which is the standard of care arm, but the experimental arm has docetaxel. Again, it's a 6-cycle or 18-week treatment. 18 weekly doses of paclitaxel will be pretty harsh in terms of peripheral neuropathy for appropriate delivery of this agent. Recent results from SWOG 17-14 suggested that weekly paclitaxel might have higher peripheral neuropathy even at the 12 weeks of treatment compared to 6 weeks of docetaxel. So with that in mind, we're not allowing paclitaxel weekly in the Arm 2 because that's a total of 18 weeks of treatment. As Dr. Mitri mentioned, patients who have a PCR can co-enroll on optimized PCR studies. So the sites that have both trials open can offer both of these trials to the patients at the right juncture in their treatment journey. Patients with residual disease for arm 1, which is the Keynote 522, again, capecitabine is allowed per physician discretion. Olaparib in eligible patients is allowed. Arm 2 for patients that didn't get an anthracycline can receive it after surgery. They can also receive capecitabine or both. It's up to physician discretion. In both arms, pembrolizumab is recommended for a whole year, but again, these patients are not prohibited from enrolling in residual disease, ADC, or other treatment escalation trials. For any questions, you can reach out to myself, Dr. Mitri, and the two SWOG emails for protocol-related or other types of questions. So next one we have is SWOG 2007, Dr. Brennan.
There we go. So yeah, just a reminder, S2007 is a study for HER2 negative metastatic breast cancer to the brain. These patients have had a prior treatment with either radiation, surgery, or the combination thereof. Standard inclusion criteria otherwise. It is undergoing an amendment. We've been waiting on this for a little while, and hopefully that will happen soon. Based on prior discussion, a lot of the radiation oncologists felt that they did not want to wait for a patient's tumor to reach 1 centimeter in size, so requested that we lower the inclusion criteria to 0.5 centimeters. That should happen soon. The other requirement will be that they have an aggregate of greater than 1 centimeter, so 2 5-millimeter lesions would qualify, and then for any response will be a minimum of a 3-millimeter response. And this is consistent with the Raynaud criteria for brain metastases. Next slide. So we're currently at about 53% accrued. We are planning for 44 patients for 40 completers. And we're seeing typical treatment-related adverse effects. Nothing really new there. We're planning to, once we get the amendment, to try and reach back out to the sites to just update them on this and get accrual moving a little bit faster. So some of the sites should be hearing from us. We'll have this active. And if there's any questions, feel free to reach out.
Thank you. We hope with the updated amendment that reduces the size, that the enrollment will increase, and it's more than halfway through. So please support this study. It's a population that is in need of better therapies. Our next study is 1706, the inflammatory breast cancer trial. Dr. Jaxi, I think, is joining us virtually.
Thank you so much. So this is our trial that looks at standard of care treatment with or without the addition of olaparib at a very low 25 milligrams BID radiosensitizing dose only during the radiation treatment. And so it's been accruing somewhat slower than we had wanted. And so you'll recall last spring my announcing that we were planning an amendment to allow twice daily treatment to try to encourage some places where that is the standard to be able to enroll. So we'll allow twice daily treatment in the control arm, and that amendment is making its way through the process, slowed a little bit by the need to also incorporate a translational medicine proposal that we had wanted to tuck into this amendment. So that will be moving forward soon.
Thank you. And then I think there is some ongoing efforts to increase awareness of this trial in all the inflammatory breast cancer support groups and other avenues.
Absolutely, absolutely. And I recorded a video about this for the Komen website. Want to again shout out to Ginny and others for continuing to keep up the attention in the patient advocate community as well.
So you have the next trial also, MA39.
Yep. And so we are championing this study, which is a large study looking at the value of regional nodal radiotherapy in patients with biomarker low risk, primarily node positive N1 disease, but also T3N0, and now some increased inclusion criteria that allow, for example, micrometastases and make it just a little bit easier to identify patients for this very large trial. As you can see, SWOG has been assigned relatively few credits for this study, but I am aware that the hard work of the members of this group are setting the stage. So for example, when biomarker tests are being ordered, I know that many of the people in this room are talking about this trial with patients and really teeing them up to then sign up for the trial, often then with the credit going to another group where the radiation oncologist is affiliated. So just again, please keep this at the top of mind for any of these patients with biomarker low risk N1 disease.
Thank you. The next trial we have up is Compass PCR study. Dr. Tang? Okay, I don't know that he might not be on.
Here. Can you hear me?
Yes.
Good. Thank you. Good afternoon. Thank you, Priyanka. Compass HER2 trial basically is a neoadjuvant trial where eligible patients are given 4 cycles of THP pre-op. Now, following surgery, if they have a PCR, they remain on the trial with 1 year of HP plus minus radiation or endocrine therapy as appropriate. Those who did not, then they are randomized to receive TDM1 for 14 cycles or TDM1 plus tucatinib for 14 cycles. And the trial was started in February 11, 2020. As of last month, 2151 participants have been enrolled out of 2156 from 926 sites, and out of which SWOG contributed 341 patients. And accrual in this year has been steady, about 40 patients per month. The good news is that if you look at the already participated patient population, we're almost there. So the study is actually expected to close next week. So on behalf of the study chair and co-chair, I want to thank everyone who contributed on the study. And of course, we are eagerly looking forward to the trial result to be analyzed soon.
Thank you. So thank you everyone for supporting this study. This study really accrued a little bit ahead of target. So that tells us there is great appetite in both patients and providers in supporting neoadjuvant trials for this disease subtype. So the companion trial to this is Compass HER2-RD, where patients with residual disease are randomized. And Dr. Murthy is our SWOG champion. If she is on, can she be unmuted? If she is not on, I will give the update on her behalf. And patients can register on this trial even if they weren't part of the Compass PCR. So the criteria is they have to have residual disease and some other risk elements with it. And the randomization is between TDM1 with placebo or TDM1 with tucatinib. The trial has accrued 490 out of 1,031 patients as of last month. And recently, in the last couple of months, it's starting to hit its monthly accrual target. You can see the eligibility criteria there. Patients who were part of Compass could have come in the study as long as they received 2 more cycles of chemo prior to enrollment. Patients with weakly ER-positive disease are also allowed to enroll, and the requirement for ALND in patients with node-positive disease at presentation has been removed. So all of those factors should help with the enrollment. And then another update that the study team wanted us to provide was there's some change or withdrawal of support from Epic Sciences for blood collection. So there will be an amendment to address the mandatory blood collection. So the next study we have is TROPION-Breast03, which is being coordinated through CTP. And Dr. Bardia, if you're online, can you unmute yourself and give us an update?
Hi, good afternoon, everyone. It's just my pleasure to give an update on this study, TROPION-Breast03. It's a collaboration, academic collaboration between AstraZeneca and SWOG. The members of the scientific committee on the slide, Solaus, Kathy, Kevin, Don, Bill and Priyanka, and greatly appreciate their support in designing the study. In terms of study design, it's a study in the residual disease space. So patients with stage 1 to stage 3 triple negative breast cancer who have residual disease after neoadjuvant therapy and no already relapse are randomized to Dato-DXd plus Durva versus Dato-DXd versus investigated choice of therapy. It's a 2:1 randomization, 2 to Dato-Durva, 1 to Dato-DXd, and then 2 to investigated choice of therapy, which could either be, as per investigated choice, either capecitabine or capecitabine plus pembro. The endpoint is IDFS. Key inclusion criteria, so patients with triple negative breast cancer as per ASCO-CAP guidelines, who have residual disease after completion of at least 6 cycles of neoadjuvant therapy, which includes anthracyclines and or taxanes, plus minus carbo, plus minus pembro. Disease of the eligible patients with known germline BRCA mutations are not eligible. The reason being that those patients should receive PARP inhibitor as standard of care. And then otherwise standard criteria in terms of labs, LVEF more than 50% by echo. The trial does have a window between the completion of radiation therapy and randomization, and that's 6 weeks. If a patient is not a candidate for 16 weeks between date of surgery and randomization. In terms of key exclusion criteria, so patients with metastatic disease are not eligible. They should receive other therapies. Patients who have history of ILD are not eligible because they would not receive Durva or immunotherapy. And patients with clinically significant corneal disease are not eligible given Dato-DXd is one of the arms. A question had come up whether patients in this clinical trial, because they'll be receiving Dato-DXd or investigated choice of therapy after radiation, and patients will not be getting immunotherapy with radiation, whether that would compromise outcomes. So this was evaluated in 2 other studies, and essentially the results indicate that completion of radiation prior to the start of adjuvant pembro does not result in EFS outcomes. So based on the EFS outcomes, it's reasonable to give radiation first, and then after the radiation is completed, then patients can get their adjuvant systemic therapy, which could be pembro or capecitabine, or enrollment in this clinical trial with Dato plus minus Durva. In terms of the current status, study of the 70 countries have been activated, 77% site activation. About 350 patients have been screened, 221 randomized. The screen failure rate is 23%, which is on the lines of the planned range, about 20%. In terms of SWOG sites, that's slightly behind plan in terms of the number of sites that are activated, in terms of all of that is behind plan. So it would be great to discuss this study and advocate for the study. As a reminder, again, this was developed by the SWOG Scientific Committee in collaboration with AstraZeneca. And we do have the AstraZeneca colleagues here in the room. I cannot see them, but I know they are there.
And I think we have Dr. Albain here also, so she wanted to add a few words and introduce our AZ colleagues.
Doctors Dentaluri and Maxwell, could you join me right up here, please, so everyone can see you? Are you here? Ah, excellent. So we've asked, thank you so much, both of you, for coming. All of you who have the study open, we thank you. We do know that, as Dr. Bardia just mentioned that it's not just the SWOG sites, it's all the US sites who are behind in activation. And we've just sent out a survey, which we hope to look at soon in terms of the reasons why. I know at my particular site, it's been the contracting that's held us up, and we're moving along with that, but we're wanting to learn if that's a uniform issue, if there are other issues. So they've agreed to come, and they are available. And if you could just say how they can contact you here, the sites that have the trial open to chat, so that you can help.
Sure. So hi, I'm Micah Maxwell. I'm the clinical lead for the study. I'm happy to provide my email, perhaps, and it could be sent out to everyone here. So you could contact us directly for any issues. We know, of course, that you have access to our kind of local US team, but also we in the kind of global team also want to be able to support everyone in being able to get the trial open and get patients recruited. So I will provide that to Dr. Sharma, and she can send it out to everyone. All right.
So, and I'll be here for a little bit right after the committee. If you want to just find me, I'll be right outside. Thank you.
So are we still looking for additional sites that could join the study?
So no, at this point we have selected all of the sites. As you saw, there's nearly 130 sites in the US that have been selected. It's just a matter of some of them still needing to be activated, and then those that are active, of course, just recruiting patients. So.
But if someone after this presentation and all these new data has a burning interest that was considering it but did not, is it still possible, given that the slow?
Probably. I can't make any guarantees, but we'd be willing to consider it.
So I think this is really an important study, and I just want to hear anybody's feedback, including Dawn's, that how could we increase accrual rates?
Yeah, I don't know if I would sort of. Oh.
Who here has it open at their site or will be opening it? Raise your hand, please.
I mean, we just got it open. I'm just saying that it's just those numbers of being behind, I think, are deceptive, because as Kathy mentioned, it took us a long time. I think we just got it activated after a lot of back and forth. So that behind rate may be related to contracting issues.
You know, feel free to contact me or Micah directly. And Dr. Sharma, if you want to send our email, just so that we can get feedback on the delays, we're happy to help address it for other sites that haven't yet been activated. Thank you.
So any other thoughts or comments from those of us online? We have actually a lot of people joining us through Zoom. So please, if you have any comments, please put it into the chat.
Someone has the hand, Ragisha?
Kathy just asked if anybody here in audience has any comments or that they want to make about the study, or are most folks just still trying to get it activated? Thank you so much for coming.
And thanks for partnering with us.
So the next study we have is optimized PCR, and we just took up a study champion for this. Our champion for this is Dr. Mitri. No. Yes, now it looks like it. Yes.
There we go. All right, so optimized PCR is a randomized study to a phase 3 study of pembrolizumab versus observation, again, patients with triple-negative breast cancer who have achieved a PCR following neoadjuvant chemoimmunotherapy. Just next. So the key eligibility is important that for these patients, they would have had at least 6 cycles of chemoimmunotherapy with pembrolizumab, and then if they achieve a PCR, they're randomized to continuing pembrolizumab to finish the 1 year of therapy or observation. Next. So the primary objective is really to see if observation yields a non-inferior recurrence-free survival compared to continuing the 27 weeks of adjuvant pembrolizumab. Secondary objectives here will be adverse events rate to make sure that we're not getting more immune-related adverse events in the adjuvant setting as well, quality of life, overall survival, and it will be correlated with PD-L1 and TILs, as well as blood will be collected for future potential ctDNA studies. And some of the key eligibility is the ER/PR go up to 10% here in HER2 non-amplified. Again, as we mentioned, 6 cycles of neoadjuvant chemoimmunotherapy, no residual invasive disease, but residual DCIS is allowed, and there will be tumor tissue collected from the diagnostic core biopsy, and they shouldn't have any contraindication to further immune checkpoint inhibition. There are about 425 pending site and 233 approved. It opened earlier this year in end of May, and accrual is at 10 patients, so hopefully we can continue supporting the study as the sites get approved through CTSU.
Thank you. So again, it's an important study, answering and answering an important question, and we're also still in the process of opening, so I'm sure a lot of sites are still in that phase of trying to get it open. Our next study is NRG BR009, or offset trial, which also recently activated, and our study champion for this is Dr. Vidal. Are you online, Greg?
I see Greg.
Can you unmute yourself?
Maybe he's not anymore.
Okay, so I might skip this one and come back to it when he can join, because there are many details to this study since it's a new trial. I am going to go to the next one. So the next we have is BR007.
Yes, can you hear me okay?
Yes.
So this is a clinical trial looking at omitting radiotherapy on patients with lowest risk breast cancer as defined by oncotype equal to 18.
Your voice is in and out. Can you mute and unmute yourself? This is not on our end.
Okay, is that working any better? Okay. So this is a clinical trial for patients between 50 and 70 who have the lowest risk breast cancer. So 2 centimeters or less, pathologically node negative, ER positive, HER2 negative, and oncotype current score less than or equal to 18. And they're randomized to either standard treatment with radiation and endocrine therapy, or the experimental arm with endocrine therapy alone. And the study is making good progress on accrual, as you can see. About a third of accrued and is just under the accrual goals. Thanks very much to everyone who's been championing this study sites. We hope to continue that enrollment. A few things that might help with that. There is a new amendment that has been submitted that will allow for options for partial breast radiation. So it can be completed 5 consecutive days. In this study, we're finding that it can at times be hard for patients to accept their randomization to radiation or no radiation. And it's important, it seems to make a big difference for them to hear about it from across the care team in each specialty. This will be a really important trial in radiation oncology that it was interesting. Results from the Lumina trial that were published just recently in the New England Journal of Medicine, which is a single-arm trial looking at radiation among patients with luminal A-like cancers as defined by case KI67, and observed a recurrence rate of 2.3% at 5 years. And I mentioned that because it highlights that we have equipoise in very favorable patients with molecular low-risk breast cancer. And so we encourage you to continue to discuss this. Thanks so much for the support.
Thank you. Our next study is BR008. Eileen, are you here or are you going to give the update virtually? So this is.
I know she was in the radiation group, so maybe she hasn't made it.
Okay, so she might still be in the radiation committee meeting.
No, I mean, I'm happy to.
Yes, I was going to ask if you would. Yes, please.
Sure. So this is a phase 3 trial of omission of radiation treatment in favorable HER2 positive disease. And so you can see here that either patients who have lumpectomy followed by adjuvant HER2-directed therapy and chemotherapy, or those who have neoadjuvant chemotherapy and then have a pathologic complete response at the time of lumpectomy, are randomized to radiation treatment or radiation omission. And it was just activated and has accrued 3 patients. So I strongly encourage you to encourage patients to consider enrolling on this important trial as well.
Thank you. Next we have is 1501. Floyd.
Yeah, next slide, please. So 1501, as you all know, is a randomized trial looking at carvedilol versus no intervention for reducing the risk of cardiac dysfunction in women or men with metastatic breast cancer receiving eligible HER2-targeted regimens. I think everybody pretty much knows this. That's fine. So this is a slide looking at accrual. So thank you to everyone who's accrued. You can see in the top left, some people have accrued very well thanks to all the sites and mostly to the patients. We have 300 patients on now. You can see bottom left, sort of our progress. And as I said in survivorship, we're sort of sputtering along for various reasons. Obviously, accrual is slower than we projected. At our last group meeting, we discussed redesign, and not long after, the DSMC also suggested we redesign, which we suspected was coming. So as we've discussed this, we've looked and sort of done some preliminary analysis, and turns out our event rate, which you remember is cardiac dysfunction, is quite low. I'll say very low. I won't get any more specific than that. But it also turns out that the observational cohort in this preliminary analysis, which obviously is not powered for any conclusions, has the highest rate of endpoints. So those would be the patients that were already on an ACE inhibitor or beta blocker and were on the observational arm. So our thought going forward, we've talked fairly extensive about this, is that we're likely going to close the randomized arm, randomized portion of the trial and reopen the observational cohort, as that has the highest event rate. And we're going to also combine our endpoint to cardiac dysfunction and cardiac events in all likelihood, and see if we can actually identify in this patient population what the event rate is, because again, it's quite low. And remember, these were patients that were high risk for cardiac dysfunction. And we're going to see if we can develop a predictive model based on this. And my thought is, if this goes as it seems, we may be over-evaluating women with echocardiograms with metastatic breast cancer, and potentially we may be able to demonstrate that and save some money for the system and save a lot of inconvenience for patients. So more to come. Thank you.
Thank you. Next we have 1703. And I know Melissa said she couldn't join, so I will give an update unless Dawn wants to do it.
So a lot of changes have, is this just one slide? Yeah, so, is this, yeah, 1703. So, yeah, so this trial is actually, Melissa made a lot of changes to make this a very easy study to do. It doesn't require all three biomarkers be done. There are wider windows, lots of things that make it much easier. We've put lots of patients on it. And as a result, like the inflection points on the trajectory of accrual have actually started to go up. But one of the things that's also happened is that a lot of other trials, pragmatic trials, non-inferiority trials have been published. So they're going back to redo the stats and re-examine the non-inferiority margins, which will likely help get this study done over the next couple of years. So people should continue to accrue, but it also is probably not going to be as big of a bar to get to.
Okay, so we'll look for updates at the next meeting in terms of resizing the trial, but not much change in the design to what has already been done. So next one is EA1183, and Dr. Specht will present this virtually.
Thanks very much. I hope you can hear me. EA1183 is FDG PET to assess therapeutic response in patients with bone-dominant metastatic breast cancer. Next slide. So you've all seen this schema in this study before. This is asking a relatively simple question. We know that many patients with metastatic breast cancer have bone-only or bone-dominant disease. And we also know that our standard imaging techniques by the way of CT and bone scan often are good at detecting metastasis, but function less well when it comes to assessing response to treatment. And the goal of this trial is to evaluate and to hopefully validate serial FDG PET as a technique and criteria to assess disease response in this patient population. And again, many of these patients are often excluded from some of our large phase 3 and registration trials for the lack of measurable disease. So the trial is a relatively simple, straightforward, single-arm study where patients that are initiating a new line of systemic therapy undergo a baseline FDG PET and then a follow-up FDG PET, both of which are covered by the study at 12 weeks. And we're looking to see if the change in metabolic criteria as assessed by PERSIST will be able to predict progression-free, time to progression, as well as time to skeletal related events and overall survival. We have additional correlative funding to evaluate dynamic changes in ctDNA, as well as an early assessment of disease at 4 weeks. The results of that FDG PET are for research purposes at this point and are blinded to both the patient and the investigator. Next slide. I'm happy to say that we are getting close to meeting our accrual goal for EA1183. We are at 128 of 134 planned patients. And I will extend my gratitude to all of the contributions from SWOG. And we've been pleased to enroll patients both from academic and community sites. And we look forward to completing accrual, hopefully before the end of the calendar year, and are starting to work on our analysis plan. I would like to thank again our champions, Hannah Linden for SWOG and Chadwick Wright, our radiology champion. And we are still open to enrollment and happy to take any questions. So thanks very much.
So thank you for supporting this study. It's almost close to the finish line. Next, we have TMIST, Dr. Arun.
Okay, a brief update on TMIST. Next slide, please. As you know, this is a randomized prospective trial looking at comparing mammograms with breast tomosynthesis in asymptomatic women ages between 45 and 75 with no prior history of breast cancer. The accrual goal is close to 129,000 women And next slide, I think, has the accrual. All the others I had presented previously about the methods, but they are at close to 89,000. So as of September, so last month, going well. I was not informed of any issues right now regarding the study. So thanks to everyone who's enrolling to this.
Thank you.
Do you know what's the target? How many patients?
129,000.
Next, we have Aspen, or SWOG 2010. Dr. Henry.
So thank you. So this is a trial, it's a randomized phase 3 trial comparing active symptom monitoring plus patient education versus patient education alone, specifically looking at improving persistence in young women at high risk of breast cancer recurrence. So we're enrolling women who have stage 1 through 3 breast cancer, who are pre or perimenopausal at the time of breast cancer diagnosis, and who are going to get endocrine therapy that includes ovarian suppression in addition to oral endocrine therapy. So far, we have, actually earlier this week, we have 98 patients out of 540. We did activate back in January. You can see on the right, the schema, it's very straightforward. Patients either get randomized to this intervention, which is basically 6 really short questions that come via phone, text, or IVR, weekly for the first 24 weeks, and then every 4 weeks for the next basically year, versus patient education alone. And it's really trying to improve patient-provider communication. Patients do have study assessments every 12 weeks. That's supposed to line up with sort of typical follow-up. If you are in, this is open to any site. It's not a limited institution study. You can get it off the CTSU. If you are a new site, make sure that at least one of your staff members does the training, and also make sure you email us so that person can get access to the website, because otherwise you'll enroll a patient and you won't be able to do anything. So it's a very important step. Next slide. So key eligibility, just based on things that I've been asked repeatedly, it is completely up to the treating clinician as to what endocrine therapy is given, but some sort of ovarian suppression or ablation has to be part of it. So you can give tamoxifen or aromatase inhibitor. For ovarian suppression, it can be GnRH agonist therapy, it can be ovary removal, or it can be chemotherapy-induced ovarian failure. At the time you're starting endocrine therapy. There is a window of plus or minus 14 days for when you can actually enroll the patient around the time they're starting endocrine therapy. We did have a recent amendment, so instead of requiring clinic visits every 12 weeks, those can now be visits with study personnel, so it doesn't have to be with a clinician. Those can be in person or virtual, but if you do virtual, the questionnaires that are completed by everybody every 12 weeks have to be done on paper, which is really annoying. But you can send it to the patient, she can print it out, fill it out, and send it back to you again. You can't do it over the phone. And the other one thing I wanted to say, because I think that was my last slide. We're going to hear about BR009. Aspen is a non-therapeutic trial, does not have any investigational agents in it. And so therefore, in theory, patients can co-enroll in those 2 trials. It may be a little challenging for patients just because there's questionnaires on both studies and they won't necessarily line up. But it is possible to co-enroll if you have patients who are eligible for both and interested. So happy to take questions.
Thank you. Next, we'll talk about 2206, Erin, in terms of a little bit more about the study design and details, since this should activate in the next couple of weeks.
Yep, so this is S2206. We already mentioned it briefly, so we'll just go to the next slide. So just the background of this, again, which we already mentioned a bit, the I-SPY2 trial, the neoadjuvant platform trial with patients with locally advanced early stage breast cancer, utilized MammaPrint within the context of this trial and has really generated the preliminary data for the S2206 study. I just want to highlight there sort of how the MammaPrint score comes back. So ranges between 0 and -1 are considered the high risk category category, and those are subdivided into MP1 and MP2, and MP2 being our particular marker of interest, which is this ultra high risk category. And then those between 0 and 1 are low risk. Next slide. So again, just highlighting that MammaPrint assay, you can skip over this part, that's fine. So the background here is, of course, that I-SPY 2 really helped us identify that there's this subset of MammaPrint high 2 patients that are not only highly chemosensitive, but probably benefit from the addition of immunotherapy as well. And you can see that in the arms of I-SPY 2, where patients that had MammaPrint high 2 results received immunotherapy in conjunction with chemo as a part of their neoadjuvant systemic therapy, there were very marked improvements in the rates of pathologic complete response. That was not the case for those that were high risk but MP1, so a little bit lower on that spectrum. Next slide. So with that all in mind, we've designed S2206, which is taking patients with newly diagnosed clinical stage 2 to 3 hormone receptor positive HER2 negative breast cancer, and we're utilizing the MammaPrint assay as an integral biomarker here. So there are 2 ways in which patients can enroll in this trial. They can have had standard of care MammaPrint testing performed on a core biopsy after their breast cancer diagnosis. And if they are MP2, proceed directly to registration and then ultimately randomization. Or if you would like to have the MammaPrint testing performed on study, it can be provided free of charge on study. Patients would sign a screening consent. There would be submission of the tissue to Agendia, and then ultimately those that are MP2 then are eligible for randomization. And then patients are ultimately randomized to either neoadjuvant ACT chemotherapy or that same chemotherapy backbone plus durvalumab. And then in the adjuvant setting, patients after they receive their surgical treatment or radiation, if it's indicated, really is all at investigators' discretion. So they can get standard of care endocrine therapy with or without CDK4/6 inhibitor. As we mentioned earlier, germline BRCA patients can also get PARP inhibitor, and their follow-up will be for approximately 10 years. So primary objective here is to test if the addition of durvalumab to standard of care neoadjuvant chemotherapy will improve invasive disease-free survival in this setting. We also have the secondary objectives of looking at pathologic complete response rate, assessing quality of life measures, and as well as a number of exploratory biomarker assessments that we talked about a bit in the translational medicine meeting. So our key eligibility, just to review, so histologically confirmed hormone positive HER2 negative breast cancer, clinical stage 2 to 3 disease, of note inflammatory breast cancer is eligible. Patients must have MammaPrint high 2 or MP2 status. That score is designated as negative 0.57 to negative 1. And again, there's those 2 mechanisms to enroll. So you can either order the MammaPrint as standard of care and then only, ultimately enroll, of course, those that are MP2, or there is an option for MammaPrint on study that is provided free of charge by Agendia, and patients would sign a screening consent before submitting tissue for MammaPrint testing. Of course, they have to have no contraindications for immunotherapy or chemotherapy and no evidence of metastatic disease. So a couple words about the MammaPrint testing logistics. So we really strongly encourage any of you that are really interested in opening this trial, particularly if your institutions are not ordering MammaPrint regularly, to register for an account with Agendia. You can contact that email address, which is customercare@agendia.com. If you contact them through email, you'll get a login detail, username, and a password for the ordering portal. And then once your account is created, you can actually order kits in advance on that portal, so that once you open the trial, you've got the kits in hand and are ready to go. For patients that are submitting tissue for on-study MammaPrint, there's the word about the tissue requirements, so tissue FFPE block or at least 10 4 to 5 micron unstained slides. Also, if you're again ordering it on study, sites have to complete the MammaPrint submission form, which is available on the abstract page at the SWOG website. And that form must accompany the sample to Agendia. And Agendia will turn around these that are submitted on study and as well as in standard of care quite quickly. This says 8 to 14 calendar days, but we have been reassured by Agendia that their typical time frame is usually in about 7 to 8 business days, so probably on the shorter end of that. So just the timeline here, August 17th, we received our CIRB approval. August 31st, we got a CTEP approval on hold pending some minor protocol revisions, which have been submitted. And late October is our anticipated activation.
Thank you, Erin. And I'm going to go back to, if I can, BR009. I don't think Dr. Vidal's on yet, but I do want to kind of talk about this trial since this just activated.
So that study is following up on our exponder to look at whether it's the chemotherapy component or isolate out the combined modality hormonal therapy as the main driver behind the benefit in the younger women with the low recurrence score.
So the studies for premenopausal patients with hormone receptor positive, HER2 negative breast cancer. If they're node negative, then either recurrence score 16 to 20 with high-risk features or recurrence score 21 to 25, or node positive with recurrence score of 0 to 25. There are 4 stratification factors, one of which is intent to receive CDK4/6 inhibitor, and the randomization is either between ovarian function suppression plus NAI or chemotherapy followed by ovarian function suppression plus NAI. And we are told that tamoxifen is allowed instead of AI in case of intolerance because of side effects to NAI. And the primary endpoint is to determine whether adding chemotherapy to ovarian function plus suppression plus AI is superior to the ovarian function plus AI in improving invasive breast cancer-free survival. And there are multiple secondary endpoints, as you can see. Eligibility criteria is it's premenopausal patients with T1 to 3 and 0 to 1 breast cancer, ERPR positive per ASCO-CAP guidelines. And if it is N0 disease, then for recurrence score 16 to 20, they must meet high-risk criteria per Mind Act TAILORx, or recurrence score of 21 to 25. PN1 with any recurrence score of between 0 to 25 is eligible. Adjuvant chemotherapies per investigator's choice, but should be at least 4 cycles of chemotherapy unless toxicity precludes the delivery. The choice of AI is per physician's discretion. Radiation therapy per standard guidelines should be delivered. And on here it says whole breast radiation therapy is required. In terms of ovarian suppression, a choice of GnRH agonist and dosing schedule is per investigator discretion. BSO is allowed as an option for ovarian function suppression. Ovarian function suppression should be initiated after chemotherapy is complete unless it is given with chemotherapy for fertility preservation. So it can be given with chemotherapy in younger women who desire later fertility. And then it is recommended that ovarian function suppression and AI are started prior to and given concurrently with radiation therapy, although it looks like it's not mandated. Abemaciclib, patients who meet criteria for adjuvant abema can take this per package label. Right now, ribo is not in the protocol, but if that were to get approved, I would assume that would be allowed. But the intent to use CDK4/6 inhibitor has to be declared because it's a stratification factor. There are some estradiol monitoring requirements in the trial, which can be either through your standard assay, although the trial strongly recommends sending the ultrasensitive mass spec assay instead of the routine RAI assays that we often have in our laboratories. And based on what those levels are, there is some guidance on repeating those assays and what to do with endocrine therapy. This provides further details on what clinical high risk is determined to be for those with score of 16 to 20. Recurrence score must be performed at the study entry and meet above criteria. And then blocks and unstained slides must be sent to Exact Science centralized laboratory testing at no cost for patients that have not had a recurrence score but had mammoprint testing as a routine care. So in those patients, oncotype recurrence score testing would be covered by the trial. Study was just recently activated, so most sites are still undergoing approval and their initial activation. So it's an important study. As Larry said, this is follow-up to our expanded trials, so please support this trial. It's a pretty large trial. And there is a similar trial that is being conducted on the European side with similar endpoints. Okay, we'll move on to our last section, which is reports from our committee liaisons. And I have the first update from Dr. Henry from the Symptom Control and Quality of Life Committee.
Yeah, so thank you. So we have a number of studies that are open or in development that are related to breast cancer. One is S2013, which is our iCheckIt study. I will say at the present time, because it's enrolling patients receiving or starting immunotherapy alone without any other therapies. There are very few patients with breast cancer who are eligible, but we are considering adding an IO plus chemo cohort, which will include triple negative breast cancer. So this may become much more relevant for your patients with breast cancer. We have the limited institution study 2205, which is cryocompression for prevention of chemotherapy-induced neuropathy, being led by Dr. Accordino. Patients with breast cancer are part of the cohorts that are eligible for this trial, and there are all the institutions have already been selected, but if you are interested, always let us know. You just heard about the Aspen trial 2010. And then there are two that we're hoping will come in the future, both are awaiting grant review. One is looking at acupuncture to decrease symptom burden in patients with metastatic breast cancer. That's being led by Dr. Heather Greenlee. And then the other is emerging from the HAZE, which is a cognitive function intervention being led by Drs. Myers and Asher. So thank you.
Thank you. So next we have radiotherapy. Reshma, are you still on?
Yep, I am.
Yes, thank you.
So thank you to Alistair for reviewing some of the translational medicine studies that we have ongoing. In addition to 1706, we continue to be interested in providing some insights relating to the use of genomic signatures and local regional recurrence. So that is another proposal that has been ongoing. Thank you to Bill for highlighting our publication recently. And then we have a number of additional studies that are in development, looking at reirradiation after breast conserving surgery, looking at the management of oligometastases, looking at combining CDK4/6 inhibitors as radiation sensitizers, and other studies that are earlier in the process of development. Many thanks to our colleagues in the patient advocate community as well for helping us to shape these studies.
Thank you. Dr. Mammon for surgery update.
The surgery committee meeting is tomorrow at 9:30 for particularly for surgeons, but anyone is more than welcome to attend. The real thrust of the surgery committee really has been secondary analyses, and we've had a couple that are either in publication or on the way to publication that are the GI space. But certainly our completed breast trials have plenty of opportunity for great secondary analyses. So if you're interested in secondary analyses with a surgical focus, please be in touch with me, or I can put you in touch with the appropriate individuals, because I think there's a lot of opportunity. Thanks.
Cancer survivorship, Dr. Moore.
Hi, so Dr. Irwin couldn't be here, and which leads to the announcement that we actually would like to offer the position of survivorship liaison to a new, maybe perhaps more junior individual. So if anybody's interested in being a liaison from breast to survivorship, let me know after the meeting or email one of us, and we would welcome that. In terms of studies, you heard about Justin Floyd's S1501 study. That's our main breast cancer study that's in the survivorship committee. We do have some very early on in development. We have a study looking at a fatigue-reducing diet, specifically in breast cancer survivors. We have a proposal for a broad cancer study looking at a sleep coaching app, and then a very brand new idea of looking at GLP-1 antagonists for patients with a BMI of greater than 30, and that's, again, very early in development. So that's what's coming.
Thank you. Cancer care delivery, Dr. Hirschman.
So I think the only study we have that right now that's real specific for breast is CREDIT. And CREDIT is intervention of financial navigation to reduce financial toxicity. And it's open to all tumor types up front. And so for early metastatic disease. And so that trial, it had initially was designed to have a caregiver component that proved to be very challenging, that there were modifications that that's optional. And since that time, accrual has gone way up. So I strongly encourage people to look at that for their patients, because the intervention is all delivered remotely. We have multiple different studies in development that involve implementation science, both in the realm of palliative care and also in the realm of possibly improving exercise delivery. So TBD on those.
Thank you. Prevention update from Dr. Arun.
So the study that relates to breast cancer is Kathy Cruz 1904. That is a cluster randomized trial for patient and providers decision support tool to increase chemo prevention uptake in high-risk patients with ADH and LCIS. Providers and patients are randomized to a standard of care education material versus the improved decision support tool. Amongst patients, accrual has been completed 77%, and the sites, 100% of the sites actually completed accrual.
Thank you. Our NCORE representative is Dr. Lammers. He unfortunately is not at the meeting this time, but he said that they are continuing to support trials through NCORE, and perhaps Dawn can give it.
Yeah, I mean, I would just say on this note, it's probably going to have a more formalized process going forward, but just like we assign advocates to trials, it's probably very important to have a community representative as a, community PI or community co-investigator, whatever it is on the trials, to get that kind of input early on and engage people during concept development. So that I would strongly encourage, as you're developing new concepts, to have somebody represented from one of the community NCORE, MU NCORE sites to be in that process early. And some committees do that really very, very well and have a very established process like lung, and others not. But I think the goal in the future will be to try to formalize that process.
So, I don't see Gayatri on online. She is our DEI liaison, but of course, we are making all the attempts to be very cognizant of this important issue of underrepresentation of minorities in our trials, and our patient advocates certainly help us through that. And all our trials, kind of now that are in development or recently activated trials, we start having those conversations early on. So, like for example, in Scarlet, it is pre-built to target 20% Black enrollment in that study, and we're hoping with engagement of our patient advocates and communities that we can reach that target. Okay, so we want to end with some announcements about upcoming funding opportunities from SWOG, from Hope Foundation, including the SEED funds, the Cortman Fellowship, Impact Awards, and Career Engagement Awards. So these are all available on the website for those of you who are interested to look up the specifics and eligibility criteria. This is 30 years of hope, a generation of impact, and they've certainly supported a lot of important endeavors, researchers. So please support Hope Foundation, and thank you.
It's great. So thank you, all of you who stayed until the bitter end, and especially the resilient colleagues who stayed on at the Zoom meeting. I think half of the participants are still there, so I really appreciate that, and thank you. And we also give you back half an hour for as a sign of gratitude for staying so long on a Friday afternoon.